I could teach anybody with enough time and a big enough budget how to do any procedural skill, but I can't download experience into your brain so that you know when to do or when not to do it. And I think that's where, especially for these critical care patients, the experience is so much more important than the actual technical procedure skill ability. It's more about knowing what to expect and how to manage a patient that's critically ill because you've done it 100 times.
Welcome to In Service, the EMS podcast, where frontline experience meets leadership insight. Hosted by Jason Falvey, a seasoned paramedic and EMS leader with over 30 years in the field. This show brings you conversations with people shaping emergency medical services today. From street-level medics to innovators on the bleeding edge of EMS, we dive into real stories, leadership strategies, and what it takes to build high-performing teams in high-stakes environments. Let's get in service.
We copy you down, Eagle.
In EMS, we spend a lot of time talking about new skills, new medications, and new technology. But what if the most valuable tool a provider has isn't something they carry? It's their clinical judgment. Today's guests are bringing two perspectives that are helping shape the future of EMS in Georgia. Dr. Allen, an emergency physician, EMS medical director, a member of the state's EMS Medical Directors Advisory Council. Through his work in emergency medicine, protocol development, physician education, and statewide EMS initiatives, Dr. Allen has helped influence how pre-hospital medicine continues to evolve across Georgia, always with an emphasis on evidence-based care, thoughtful clinical decision-making, and strong medical oversight. Chad Huff, an experienced EMS leader whose career has focused on building high-performing systems through leadership, education, quality improvement, and operational excellence. His work developing providers, strengthening clinical culture, and implementing progressive EMS programs has made him a respected voice both within his organization and across the state. Together, we will explore where EMS is headed, from expanding scope of practice in critical care paramedicine to point-of-care ultrasound, quality assurance, data, AI, and the growing role of medical direction. But more importantly, we discuss why experience, mentorship, and sound clinical judgment will always matter more than simply adding another procedure to the toolbox. Let's get into it. All right. Good morning. Welcome, Dr. Allen. Chief Huff, how you doing?
Good morning. Thanks for having us.
Yeah, great. I'm glad you could do it this morning. In today's episode, we're going to be talking about the scope of practice in Georgia, or the future scope of practice. We're going to talk about the differences between skills and clinical judgment and how that ties into scope of practice. And we're going to get your perspective, Dr. Allen, on being a medical director. And we're going to talk about leadership as well. But before we do all of that, let's find out, where'd you grow up, Dr. Allen? Where are you from?
I grew up in Indiana, a little town in north central Indiana. It's the amateur circus capital of the world, a little town called Peru. I went to med school in Indiana and then residency in Augusta, Georgia. Kind of made my way through the southeast, landed in Atlanta probably 8 or 9 years ago, and have been here ever since.
Wow, fantastic. How about you, Chad?
I was born in Decatur, Georgia, Decatur where it's greater. I ended up in Ackworth is where I grew up, and I'm still living in Ackworth today, so I've been there for about 42 years now.
What motivated you to get into the fire service or EMS?
Whenever I was growing up, I played a lot of baseball, went into college, started coaching college baseball, and it was the closest thing I could find that was still a team environment, that we had the camaraderie, had the family, the team aspect of everything we do. And my brother-in-law was at the city of Woodstock at the time, at the fire department, and he pushed me towards the fire service, and appreciate it every day now. He's been with Atlanta for 27 years now, and I've been in this for 20 years, and it's the closest thing I could find to truly being like a team sport.
Yeah. You know what I was thinking? I grew up playing ice hockey, and yeah, it's probably what drew me into this as well. But how about you, Dr. Allen? What got you into being a physician?
Looking back, it's something that I'd always wanted to do growing up. I don't know that there was really one event that drove me toward medicine, but if you ask anybody I knew in high school, that's all they said that I would end up doing is being a doctor. Once I got into med school, I gravitated toward emergency medicine, mostly because I have a relatively short attention span. So
you're a high-speed guy.
Yeah, I like dealing with acute problems and not having to follow them longitudinally. So emergency medicine was the specialty I gravitated toward. And I was fortunate getting into the residency program in Augusta. They have a very large operational medicine program there. So being involved with tactical medicine, the fire department, EMS, that drew my interest, and I've been fortunate to stay involved in that arena since then.
Great. Any cases stand out over the years?
They all kind of
sure
run.
You've seen
They all
it
kind of
all,
run
too.
together. There are some good ones. I remember one of the first cases when I worked at a trauma center in Northeast Atlanta. I had a guy that was in the backseat of a car, had a pole barn collapse on him, and a 2x6 impaled him in the chest. And
Wow.
that's one of the first cases at that facility that I had that really kind of stuck with me. But I think being able to impact people that are potentially the worst day of their life and being able to make a difference in that difficult time is the most important piece for me.
Yeah. And guide and direct people out in the field.
I think the other piece about being a medical director is being able to affect the care that's delivered to a much larger group of people, and being able to impact the care that's provided to them is something I really enjoy doing.
How about you, Chad?
I don't think there's really a call that has carried me throughout my career. What I can say, the type of call, like Dr. Allen said, we only see people at their worst usually. I was fortunate to deliver 6 babies in a 3-month period.
Wow.
We see people at their worst, and that's the only time we see them. So to actually have the ability to do that and bring people into this world and see people at their best at that point is probably one of the biggest things that I've remembered in my career.
Yeah.
Is that you just see so many negative things, and to see positive things and positive aspects. We don't usually carry that. Usually nobody wants to run a baby. Nobody wants to deliver a baby.
Yeah.
To me, it's one of the biggest things that I've held close to my heart for a long time.
That's awesome. Let's talk about the future scope of practice for EMS in Georgia, and what should EMS providers be able to do 5 years down the road from now that they're not doing today? Do you want to give us a little bit of your background on that as well?
Yeah, I think EMS has really developed over the last several decades, right? I mean, initially it was nothing more than a cabulance, basically. It was a ride to the hospital with really no medical provider in that vehicle.
Yeah,
So-
we ran 30 years ago Cadillac ambulances with a sink and a stretcher, right?
Yeah.
That was it.
And so now I feel like we're really pushing the envelope and delivering a lot more care prior to getting to the hospital, impacting destination decisions and providing medications that really have a significant impact on the patient's outcome. The challenge for me as a medical director is making sure that the things that we're pushing out to our crews are evidence-based. There's really good evidence to support us doing that in that pre-hospital environment. Making sure that the people are trained on how to do it effectively so that it's not dependent on the crew that shows up or the zip code you live in, what particular crew is responding to your calls. Just making sure that we're giving that kind of uniform delivery of care across our service area.
Yeah, I think he's right. I think that we've done a good job in the state of Georgia of trying to progress things over the last several years. Geographically, we're just so widespread as far as rural and urban areas go, and trying to keep the scope of practice centered around the urban areas for so long, and now opening up to where you're involving the rural areas. Now, it comes down to the medical directors in each region or each organization to decide what the needs are for their community and the areas that they're serving. And that's the biggest part for me. Whenever we start opening up the practice, I always get concerned about education and the logistical things that come into play. In my organization where I'm at right now, we have 500 personnel with about 220 paramedics. The challenges come of how do I get all these people trained to the same level? And financially, is it feasible to put this on every single apparatus that we have, or is it strictly for transport units, or is it strictly for medical supervisor units? I think that they've done a good job. We as providers as a whole need to do a better job of educating and maintaining that education over the course of time. They're low frequency interventions that we're getting now, like ultrasounds, the blood products, all these things that are coming into the field. We're going to have to stay on top of it, just like we would expect the doctors or the technologists at the hospital to stay on top of those things. Ultrasound's one of those things specifically for me. If you don't see stuff all the time in that ultrasound, you don't know what you're looking at.
Right.
being able to direct that thing. I believe are beneficial in the field. We have to figure out a path to push those out there and maintain that educational piece to it.
Yeah. And the county you serve is almost 350 square miles, is that it?
Yes.
With a population of about 305,000, somewhere in that neighborhood?
And growing, yes, sir.
Yeah, I can see it. That's a huge territory to serve. Spread out, congested suburban areas, urban areas, as well as very rural. So you've got a really big challenge there to be able to consistently deliver care across that.
Absolutely. 60% of our county is within 2 cities. We have 2 major population groups, one in one area and one in the other, and the rest of it, we're pretty rural when we think about it. So we even have challenges, and I say that with the state of Georgia about the challenges of the urban and rural, but we have it as well, just inside of our county. We have to make decisions about where we're going to strategically put things, medications or treatment options. Some treatment options are beneficial in some of these rural areas, where in these other areas, they can be at a level 1 trauma center in 5 minutes, 10 minutes.
Right.
Doc Allen oversees not just us, but another place that's even more rural. So the challenges that they face, he looks at ours as a medical direction, but he's also got to look at that county specifically as well, because their needs may be different than what we have, strictly because they don't have the hospital systems that we have around us and the capabilities of those hospital systems. 20 minutes away, that can make the difference in life and death, and they may need something completely different than what we need.
And you're looking at, to a level 1 trauma center right now, the closest one to you is about 20, 25-minute drive from the center of the county?
The way our county sits right now, I can be at a level 1 or a level 2 that could handle it in about 25 minutes from just about anywhere in the county. With a major highway running down to one of them, it makes it a whole lot easier. And then there's another, it's not a major highway, but it's a significantly sized highway to where we could get through fairly quickly to the other one.
Yeah.
And we're fortunate in that aspect.
Yeah. Now, we'd mentioned, we spoke briefly on the phone about helicopter services, and it's not really something you do here, though.
With us being able to get to a facility like that within 25 minutes, by the time you look at ground clearance, takeoffs, them getting in the air, travel time to the scene, and then dropping down on the scene, there's certain times that we need to utilize it, and 99% of the time we can truly make it to one of those facilities.
Yeah, just ground pound it.
Absolutely.
Yeah.
I think if it's a situation where you need a service or a skill that the helicopter crew can provide, that's a different animal. But most of the time, our guys can provide enough stabilizing treatment in the same amount of time, if not shorter, to get them to the facility sooner.
Right. Especially with the blood products coming on board. I think one of the last times me and you talked about, and we did land a helicopter on a scene, it was 3/4 of the reason was because of the blood products, the capabilities of the blood products at that point.
And you've closed the gap on that.
Yes.
So what procedures or medications that are currently restricted are you looking at or considering?
Yeah, that's a good question. We're fortunate in Georgia that the EMS Medical Directors Advisory Council is fairly proactive at looking at things from an evidence-based perspective. Like Chad said, we have a dichotomy in the state in the rural areas and then the metro Atlanta adjacent. So you have to look at things that are applicable to both and take into account the medical director oversight, the agency's ability to oversee that program. There are things that always come up like RSI and blood products and finger thoracostomies for large traumatic pneumothoraces, tension pneumothoraces. Those are skills that you can teach fairly easily, but it's a matter of making sure that you have the oversight to ensure that once you implement them, they're appropriately delivered, the complications are managed, the indications are very specific in the protocols. And so it's not just something you can say, we're going to do this tomorrow and then roll it out to the field. I think there are things, we're looking at POCUS, we're looking at RSI, especially at the critical care paramedic level, which is something that the state recently implemented as a new endorsement to the paramedic licensure. I think there are things that we're doing that are trying to advance the skill delivery that the paramedics are able to provide, but doing it in a manner that's appropriately supervised and not dangerous for the patients.
Yeah, the biggest part is letting the other people, the idea behind it is to put on the medical supervisors' vehicles and the command staff's vehicles so that it's isolated to certain areas, because a lot of those programs are a large financial uplift. and a large educational uplift. Everybody needs to understand why and what we're doing them for. So they all need to go through the training, but you also need to have that level of care to where there's multiple people involved to make that decision whenever it comes down to something that's a critical care level position or intervention. I think he's exactly right. The maintaining that educational piece of any of those new things that we do is going to be huge for us. And me and him have talked about it plenty of times about the RSI thing, is that I would have to get into one of the hospitals, hopefully, and build that relationship with them to get our guys that are truly critical care and have the ability to do RSI in there quarterly so that they can actually do or into labs so that we can maintain that skill. And we just don't do it enough in the pre-hospital setting. We talk about it all the time, and everybody always wants to hype it up like it's something that we do nonstop. But in actuality, I don't know that I have anybody that's done it more than 5 times this year.
Wow.
I think when you have airway adjuncts that are often just as effective, I think the number of times that you truly have to RSI somebody is way lower than what we would actually anticipate it to be. I think one of the things I see looking at kind of the national level, the profession has become really kind of over-indexed on procedures. It's all about what procedures can we do, what medications do we carry, what devices do we have. And I don't think we focus enough on the clinical reasoning behind why we do some of the things that we do. I think it's more important to understand why you don't have to intubate somebody than actually being able to pass it. Passing the tube is largely the easy part of the procedure, right? It's really understanding what corner you can box yourself into by trying to provide that procedure to somebody who really doesn't need it. Understanding the ramifications of those procedures, I think, is something that's underrepresented in the profession.
Because you're going to commit time to doing that procedure and securing that airway. Is that really the best use of time?
Yeah, to the detriment of something else, perhaps. Especially looking at cardiac arrest is kind of a big focus for us lately. So if you're fumbling around trying to get an airway, trying to get somebody intubated for 5 minutes when you could have just put a supraglottic airway in and gone on to the next step.
Right.
You really have to understand that there are ramifications to what you're doing to the detriment of perhaps something else that's more beneficial to the patient.
Yeah.
Another part of that is the provider that you're giving these tools to. I've learned over my career is that just because we have the capability doesn't mean we need to. And then there's certain individuals that are a little overconfident sometimes, and they utilize treatments just because they can and not necessarily because they need to. We've talked always about the lowest level paramedic, but I also talk about the ones that believe they're the highest level and truly aren't. Those are the ones that scare me more than anything, because usually your lowest level paramedic's not even going to step to that drug. They're going to look around it and try to find ways not to use it. Whereas that one that's a little overconfident, a little overzealous, is the first one that's going to grab that drug so they can be the first one to say that I utilize this specific treatment. And it may not even be on the patient that they need to be utilizing that treatment, but at least they got to use it in their eyes.
Yeah.
That's where trying to find the right people for the critical care stuff is truly important to me. Making sure that we have the right group of individuals that are going to push it forward positively in the future. Because if you start a program like the critical care program and you get the wrong individuals involved, it's going to set that standard. And it's going to set a tone moving forward about what kind of people that we need in that position and what they're willing to do and what they're not willing to do. And I just think trying to find that good balance of individuals in that role is going to be key for any organization that decides to go into something like that.
Yeah.
And I think looking at from a protocol development perspective, he and I talk about this fairly frequently. You have a bell curve of providers, right? I mean, there are people on both tails of that bell curve. And the protocols really have to be designed for those two extremes of people. So making sure that the overconfident paramedics are appropriately reined in, I guess, for lack of a better word, so that they don't have access to things that they maybe shouldn't be doing. Taking the guys on the left end of the bell curve and giving them some tools to advance their practice, to be more confident, to move up in their level of capability. So it's a fine balance when you start looking at things that larger systems are doing that are more progressive, and finding that balance between what works best for our agency and our providers and our level of risk tolerance.
Right.
I'm glad he said that, because our organization right now is we do have 220 paramedics. So on any given scene,
Which is a big number.
absolutely. When you get on a critical scene like that, you've got multiple that are there. So you're getting a balance of both usually. You're not usually getting a group of that paramedic that's not very confident and a whole bunch of confident paramedics. You're getting a balance of both, or all of them.
Good mix, right?
And they're feeding off of each other. They're communicating with each other, and that's beneficial for us right now, because they're not just coming off of an ambulance. They're coming off a ladder truck. They're coming off an engine. They're coming off a rescue, and they're all kind of coming together in one, working on it together. We are fortunate in that aspect at this point.
And actually, it makes for better care, I think.
Absolutely.
Yeah, when you have a good mix. Do you think there is a skill, a procedure, or a medication that physicians are hanging on to too tightly?
I think it's such a loaded question, because it depends so heavily on the service and the medical director, the agency that you're talking about. You have services like helicopter EMS where they have a lot more advanced capabilities based on the resources that they can bring to bear, but they also have much more engaged physician medical direction and training in QA.
Yeah, and robust quality assurance, yeah.
I think that really drives what you can put out into the field. Having been involved in the Medical Directors Advisory Council here in Georgia for quite a while, I think we have a good mix of physicians from all those different types of services. I think people are very progressive in the care that we want to provide to our service area, but at the same time making sure that it's appropriately delivered and done with evidence-based backing and good support from the agencies. So, there are things that I think we'll see in the next 5 to 10 years. I think you'll start to see C-collars come off of trucks on every patient. I think you'll start to see point-of-care ultrasound. I think you'll see some more advanced procedures, but I think it'll be delivered in a manner that makes the most sense for that particular agency.
In Georgia, in my opinion, is very progressive.
It is. I mean, there are certainly states like Texas with the delegated practice model where you don't really have a state scope of practice and they can do anything the medical director says they can do. But for the environment that we operate in here in Georgia, we have a very engaged Office of EMS and Trauma. And if there are suggestions to the scope of practice, they're very receptive to those. And it goes through subcommittees and committees at the state office level. And they're always willing to listen to suggestions.
Right. And for you, Chad, the hurdle is quality assurance, right?
Absolutely. And we do a very good job of the QA/QI process. Every report, it doesn't matter what truck it came off of, every report right now is getting QA'd, QI'd to make sure that we're meeting the standards with these treatment options. Whenever we change something like the blood product, we made a dashboard so that we could watch to make sure that we're meeting the standards. And we're going to find areas that we need to improve on or adjust. And that's the biggest part of it. You can't set something in place and expect it to stay the same forever. Is that we're going to learn from every single process that we implement about how to do it better the next time or how we need to adjust it that time. And that's what we've learned a lot from, I think, the blood products as a whole. It's been minimal, but you see how different places react. You look at angles that you may not have looked at specifically, but how it affects that organization when we drop those people off, how it affects everything. So it's been a good experience for us. So when we start implementing more advanced options, we start looking at that in a wider range, and then we can work together to fine tune that training and get it out to everybody.
And we talked earlier about first pass on intubation and tracking that. And that's really a challenge too, the quality of the data that you're getting.
Yeah, it's interesting when you look at PCRs. There's two distinct sections, right? There's the narrative, which is the story that the paramedic tells. But the data fields drive the data collection on the state level. It's not uncommon for those two to have significant mismatches. Number of intubation attempts is 1 in the data fields. And you look in the narrative and it's 2 or 3 attempts to get the tube in place. So, I think it's important to make sure that the data that we're collecting accurately represent the care that's being delivered, because that's really the only way from an epidemiological perspective, from a bigger picture perspective, we get enough information to be able to change how we do things. Unfortunately, at this point, we're not able to pull information out of the narrative. I'm sure at some point AI will help us pull all of that information out. But right now we're relying on the individual provider to accurately document what they did. I think that's something that we'll see going forward. It really impacts, looking at those data really impact how we change our processes or we change our training to reflect maybe a step that we missed.
We've been having training sessions every morning for the past 3 weeks, and I've been standing up in every single one of them because I'm trying to collect as much data as I can to help a local facility decide what they need to provide for the community. To me, that's huge as a partnership. I've got to be able to give them the data to where they need to grow, because if they grow, we all grow. But one of the things that I told them is it's the stroke assessments is one of the biggest ones. And them figuring out if they put down weakness, they don't have all those other drop-down boxes that come with that stroke assessment.
Oh,
and then you look and you realize it. And I've told all of them, every class that I've sat
it's like
in
Pandora's box, right?
Absolutely.
A nesting doll or something.
It's like I told them, I said, I can see everything y'all doing, but you're not giving me the data that we need to help us grow, to help others grow. Like trauma is another one, is that if they click trauma, it gives them 7 more drop-down boxes, and therefore they don't want to fill that out. So they just put pain to the leg. Well, that femur's sticking out. That's not just a pain. That's a trauma call.
Yeah.
And we've been addressing that and how much it does impact the data that we get, how much it impacts the drive of where we go, which directions we go with future protocols, procedures, things like that, and the needs for us in our community.
There are metrics that you have to track and report through to the state and upward from there. But you had mentioned AI a few minutes ago. I was talking to a gentleman a couple of weeks ago who was saying there's technology they're looking at now where it will record everything being said on scene and interact with your monitor and fill out your PCR for you. If it takes you 3 attempts to get a tube, it's going to know that and record it all. And then you just have to read through it and sign off on it. And the debate is, do we really want that?
Well,
I don't know.
I saw this product last week.
Oh.
It has a dictation tab on it that will record. You can put it in the action area, and it's beneficial in ways. And then it's in other ways I could see it being non-beneficial. I could see it being a liability, legality issues, things of that nature. It is technology, I think, and whenever he talks about AI, I think we might as well embrace parts of it and create policies and procedures around those AI things. They're going to be utilized whether we like it or not. And I would rather them utilize it inside of that PCR system or whatever system that we're utilizing than for them to go out into one of the external ones, the internet-based AI programs. And that's probably what you're seeing a lot of right now in narratives, which has got the most detailed descriptive parts of it, is that they're writing it in a AI platform, copy, paste, and moving it over. I would rather them write their own.
Right.
I have to embrace it at some point and say, this is coming, whether I like it or not. How do we make policies and procedures around it to control it the best we can?
Right.
Yeah, we see it in the hospital. There are a couple of platforms inside the EMRs that we use that do the same thing. You set your phone down on the counter, and it basically will draft your entire chart by the time you get back to the desk. I have hang-ups about where those data go and how it's being collected and saved and utilized. So I think he's right. It's not a matter of if, it's when, and we have to be prepared to appropriately utilize that resource. At the end of the day, it will make data collection better. It will make PCRs better. We'll get more actual reflection of care delivered, but we have to make sure we're doing it in a manner that protects patient privacy, protects the data. At the same time, it accurately reflects the care that we're providing.
Right.
I think the biggest concerns that I have is, especially in a hospital system, you're in a controlled environment. I think everybody minds their P's and Q's a little bit better inside of a hospital environment. And like you said, Doc, you can set it on the counter and it'll record the dictation parts of it, record everything. When we get to the back of an ambulance, chaotic, or on a scene or anything like that, I guess I get more concerned about what it's recording and what it's not recording. The system that I looked at said it only picks up the medical information and it's supposed to drown out the rest of the stuff. I don't know that that's a feasible thing, and that's where testing and all that stuff comes into play.
It may do that on the back end, but there's no way that it's doing that proactively.
And that's what I said. Some of the questions that I asked is what happens to it once that PCR is complete? Where does it go? Is it admissible in court? What are the things that come into play at that point that I've got to look at on the backside to protect all involved? Now, law enforcement's doing it in a lot of places right now. Those body cameras are doing the exact same thing as what we're talking about. Those body cameras are actually filming and filling out their reports at the same time. I know there's been a big push in EMS to wear those body cameras. And those are things that I think I see coming in the next several years in order to protect everybody.
It's not like we're not already being recorded by the person on the sidewalk with a cell phone camera.
Yeah.
Absolutely. It's actually, in my eyes now, with the number of cameras that you got out there, it's the only way you're really going to protect yourself based off of you're being recorded at some point, whether it be at a house. I know a lot of these assisted living facilities that we're running into, the nanny cams are being put into a lot of those places by family members and stuff like that.
Yeah.
And those are things that aren't controlled by us in any way, shape, or form. So therefore, I don't.
But you're still responsible for the content that that they record.
Absolutely.
So I think if you have a body camera that you're wearing, 100% that your actions and your words are being recorded. So I think for some people, it helps them toe straight and narrow a little bit more.
It definitely changes a personality fairly quickly about how you're going to engage with others. So you're correct.
We talk about new skills and medications and equipment and technology, but is the bigger issue here really clinical judgment?
I think 100% it's less about the technical aspects of a procedure that you can perform, because I can teach anybody with enough time and a big enough budget to do basically any skill that I learned as a physician in all of my years of training. What I can't really teach. Well, I mean, I think if I have enough time and enough money, teasing. You can do anything as far as training goes.
Right.
But it's much more difficult for me to be able to train somebody about identifying when or when not to do a particular procedure. One of the biggest conversations I have with the residents is, yes, we can do that, but here's why we shouldn't. These are the potential complications by, not resuscitating somebody first, or not getting all of your equipment set up before you, push the medication. So I think that's the piece that we don't do as good a job with paramedic education.
Right, and I think experience plays into that. How many of these cases have you seen, and what were the severity ranges?
Exactly. Yeah, it's funny. I had a resident the other day. We had a patient with some orthopedic injury. I look at the x-ray, I told him what I thought it was, and we go see the patient, and it ends up being that. He looks at me, he says, "How did you know that without having seen the patient?" I'm like, well, I've seen a couple hundred of these in my career. Before you have that experience, you don't know what you do or don't know.
Yeah.
I think it comes a lot to do with how they do their assessments now, too. What I've realized is with a lot of the youth is that we have a lot of tools to do assessments that tell us a lot of different things. But we always jump to that first thing we see and want to treat that first thing we see. And it's not necessarily always what's causing the bigger picture.
Right.
We do have the ability, like end-tidal CO2 is a huge resource for our crews that doesn't get utilized enough. It's something as simple as a thermometer. Tells us a lot about something that we don't utilize enough. That's another thing that we've been training on, is trying to stay hyper-focused on making sure that we have all the details before we make a treatment decision that we can't take away. Once we give that medication, I can't take it back.
Yeah, once the plunger is pushed.
Yeah, that's one of my biggest things. Whenever I'm speaking, I try to talk to people about it, making sure that they have all the information before they make a decision. There's going to be critical situations where you got to try to make a decision quickly, but that doesn't mean you can't. You've got people back there. Utilize those people to get the assessment done. Find out everything you need to, then work from there. As I get older in this, longer in this, I realize that I was probably one of those people years ago that would go straight to try to treat somebody before I had all the stuff. I find myself getting frustrated with people going straight to medications and not doing a further assessment, especially in situations where a patient's not truly about to code on you. It's not a true critical situation, and looking back and saying, is this the direction I need to go, or is this causing this? So let me assess this person a little bit better.
You got to figure the number of patients that actually require an immediate life-threatening intervention is pretty small.
Yeah,
very minimal.
It's very small.
Do the assessment. What do you think, what decisions do you think paramedics should be making independently? You mentioned Texas, right? Where do you fall in that range? What are your thoughts?
As a medical director, I know a lot of people that work in Texas, and the paramedics largely love working out there because I think they can operate at the very edge of their license. From a medical director perspective, the liability scares me a little bit, not being on the scene, but still having responsibility for the care that they're providing. I think I sleep much better at night being involved and engaged in the training that's developed and the supervisors that I know that are out there that can provide the medics on the street with good information to make the right decision. So from a progressive or not perspective, I try to lean more toward the progressive end of providing tools to our paramedics and providers to be able to operate at the top of their licensure, but at the same time making sure that they're protected and the patients are protected as well. So I think I skew toward the more progressive end of that spectrum, but I try to be as pragmatic as possible about it.
I think by having the medical command staff on shift, it bridges that gap between the field personnel and him. We have a lot of youth still, and it's good for them as well because they're learning what he is okay with by working independently. The medical command staff that's on a day-to-day operation, they have direct access to him all the time. They pick up the phone and they call him if they have a question. Every time they do that, they're learning something about him. And that's the biggest part of it for me. Whenever they're calling a hospital or they're feeding information to a hospital to try to get guidance on something, that's a different provider every single time. My medical command staff having access to him and asking him questions, that's our medical director. It makes it easier for them to work independently in the future whenever they have the ability to do that. They know how to guide these people better based off of what he is telling them. So it works out better. And I think our medical command staff does a good job managing everything before it ever even gets to him. Now, they're still learning too, just like anybody else that's in this profession.
I try real hard when they call me to not just give them an answer. We try to talk through it. I try to give them the information to be able to make the decision themselves so that it's not just, this is what Dr. Allen told me to do. It's, this is what I'm thinking, this is what he's thinking, and this is the decision that we collectively come to. I think it's important to give them that opportunity to learn from those conversations.
And you're trying to gain insight into their mindset on a particular.
I'm trying to see the scene through their eyes, what they're telling me, and I'm trying to direct them on the information that I need to help them make the decision that's in the best interest for the patient. I try really hard to make that an interactive process and not just a dictated decision that I'm giving them when they call.
And when I was on the medical command side, I loved it because I learned my medics and I learned where their weaknesses were, where their strengths were, what they were going to call about. And I see it with him as well, is that whenever they call him, they usually call me right after. Hey, I called Doc just to let you know. And it gives me insight into the command staff that I have and where they may need to work, where I need to make them more confident, where they may lack a little bit. I'm only as good as they are. The more we can give them and the more we can boost them up and give them independency, they feel more confident in that independence. Our protocols are very good, but there is always those gray areas. Mm-hmm. And finding those gray areas and working through those gray areas with him and them working through those gray areas, they know how to handle it for the next time and the next time. And they get to feed that information to the people underneath them. And it's fun to sit back and watch the effect from them calling him to it going downhill and it never becoming a thing again.
You had mentioned capnography earlier. Do you think that's an underutilized tool?
I think it doesn't really cost much, and I think it can provide you some significant information on a wide variety of patients before the other vital signs start to reflect a change.
What would you like to see it used more?
I think there are things like sepsis and cardiogenic shock that I think the data really haven't borne that out yet. But I think from a patient perspective, if you start seeing a change in that number, it prompts you to go back and do a thorough assessment again and trying to figure out something that you're missing. So I think it is largely underutilized, but I think at the same time, we could also do a better job of training our people to know what that number reflects. It's not just another number that you've got to put in your PCR. It's reflecting the patient's condition, and it's another trend that you can use
metabolically
to,
what's going on.
Yeah, it's another trend. You can try to identify something earlier rather than having to react to a decompensation down the road.
Yeah.
With us using blood products now, we've been pushing it on a lot of the traumas to see if we're getting a drop in that end tidal, a traumatic situation where you're really not seeing anything, and they go from a 32, you start watching their heart rate go up and their end tidal's dropping. It tells us that we probably need to be looking a little further at this. It's another sign for us to know that there is something going on, that this person is not perfusing adequately, and we've got an issue that we need to address. I'm a huge fan, and we're actually teaching it right now in that training session as well. We hit it in just about every single training session. So.
That's good. You talked about the conversations you have with some of the MedCons. Outside of that, how do you develop clinical judgment in a paramedic? That's a tough one, right?
That's a tough question. Yeah. I mean, I think it really comes down to, getting them the widest variety of experience and providing closed loop feedback, right? It's difficult to know whether the decisions that you made were correct or not until you have that closed loop feedback on patients.
Especially because you're not actually seeing that patient, neither one of you.
Yeah, and the paramedics drop them off at the hospital, and for the longest time, that was the last they heard about them. We're fortunate here to partner with one of the local hospital systems to where we're starting to get some outcome data, so we can look back at those patients that we deliver to their facility, and we have an understanding of their hospital course, their final diagnoses, whether our impressions were correct or not. And we can hopefully use those data to try to improve that experience that we give our paramedics. So I think the biggest thing that we can do is just providing them that feedback that this is what you thought, this is what the patient actually had. If those match, then great. If not, this is what you could have looked for. And so having that HDE data, I think, is invaluable in terms of helping to build that experience.
Like I said before, the 220 paramedics makes it easy for the judgments to be a whole lot better because it's a group of people making a judgment, usually. And that's the biggest part of it, is that we put out a school of 32 paramedics, 30 paramedics. I know they're hitting the street with 3 other medics at their station, 4 other medics at their station. So even if they're brand new and they're going out to...
They're not on their own. Yeah.
That makes me feel a whole lot better. I know where I was whenever I got my medic, and I was on a truck the next day by myself. I don't care who you are. You're scared to death first thing right off the bat.
Yeah.
We can pretend like we're not, but we were.
Yeah.
I think we all ask our colleagues too. I still ask colleagues when I'm working a shift in the emergency department. If I have a question about a patient, I still go ask somebody who I'm working with. So I think having that resource as a new paramedic or even a seasoned paramedic, to have somebody else on your shift that may have a slightly different patient experience than you do, I think is invaluable. I think that's the only way we move the needle, is that we try to give people the opportunity to be set up for success. We're not putting them out on a lifeboat with no resources and expecting them to operate at the highest level of their licensure. That's just not setting somebody up for success.
And I see that at a lot of organizations, more of the rural organizations that are hurting for paramedics. You get your medic and you're thrown to the wolves right off the bat, and next thing you know, your confidence is destroyed, and that morale is absolutely defeated right off the bat as soon as you get your
sink or swim.
Yeah, your paramedic license, and trying to rebuild yourself from that. I mean, you're walking into something that you're unsure of, and right off the bat, you get hit hard with a bad call. And
you feel like you have no backup,
Yep.
right? I think that's the important piece for our people, is to understand that they have the support of an entire organization that wants to see them succeed. And we're not expecting them to operate independently to make the right decision 100% of the time. Going back to working with the residents, I make all of them come to me with a plan. You can't come to me and say, I don't know what to do, just tell me. You have to come up with your own plan. And then we'll work through it. We'll make sure that your plan isn't going to hurt anybody or have any consequences that we don't foresee. But you have to come up with your own plan, and then we have to figure out how to work our way through it. And I think having an organization where people have the backup to be able to make those decisions and not feel like they're out on their own is important.
And that plan they're offering does help inform where their clinical judgment is.
Yeah, 100%.
It's funny you say that, because I do that with the MedCons. So like before I'll take anything to him,
Yeah.
And they'll come to me about, hey, can we do this with a protocol? Can we do this? I said, come up with a plan. I said, I'm not taking it to Dr. Allen without a plan. And if you need help with that plan, I'll be more than happy to help you with it. But before we take it to them, we're going to have a plan about what we're going to do, why we want to do it, what's the evidence behind it, and is there a need in our community for this?
What are the potential ramifications?
It's like complaining to your boss without bringing a solution, right?
Yeah,
Then you're just complaining. So.
Yeah. Nobody likes that. C-spine clearance is a perfect example of EMS moving away from protocol-driven medicine. Is it really about neck injuries, or is it about trusting paramedics to be able to make that decision?
Yeah, C-spine clearance there's been a lot of debate about it. And I think the benefit to that is that if you move that direction, it doesn't require any additional equipment. It's really just training driven. There are some good studies that looked at a lot of patients that applied the modified Canadian C-spine rule, and they didn't miss any significant injuries. I think
I was just reading some data on that the other day.
Yeah, my big hang up is that you're trusting your people to subjectively interpret those criteria, right? What really is a distracting injury? What really is intoxication? Being able to appropriately interpret those subjective criteria drives the entire C-spine clearance protocol, right? Getting comfortable as a medical director that they're going to make the right decision in the moment is where I think people get some hang up from it. But the data really support it. If you appropriately apply those criteria, I think you're not going to miss anything significant. And also, you have to look at patients that are self-splinting, right? If their head is in a particular position, that's the position that probably hurts the least. If you try to put them into a rigid collar and manipulate that C-spine, are you going to cause more potential injury? It's an interesting debate. I think there are position statements from NAMSP and the Commission on Trauma that are really moving us in that direction. So I think C-collars are going to go the way of the dodo bird pretty quickly.
Yeah, yeah. And, God, for years we were standing takedowns, right?
Yeah.
Wow.
I think the other piece, too, is when you looked at full spinal immobilization, those patients had more imaging studies, longer lengths of stay, more radiation exposure from all the extra CTs and x-rays. If you appropriately apply the clinical decision rules that we have, I think the data supports that you're not going to miss any significant injuries. But again, it comes back to making sure that everybody is appropriately applying those subjective criteria to the right patient.
Yeah.
I think you're 100% accurate on that. That's going to be the challenge. It took an act of Congress for them to put C-collars on whenever we switched from long spine boards and full immobilization to the C-collars. So it's definitely going to be a challenge trying to get everybody to do it the right way.
I think if you look at the same patient and you take all 220 of our paramedics, right? Mm-hmm. We're not going to get 220 people to apply those subjective criteria the same way. So
it's a challenge.
How do you get that inter-rater reliability to be as high as possible in favor of the patient, right? It's a challenge. Definitely is a challenge.
That's the concern, right? That you're going to miss something. Mm-hmm. Somebody's going to...
Yeah, the last thing you want to do is not immobilize somebody, and then as you're moving them from the EMS stretcher to the hospital stretcher, they end up with a spinal cord injury, right? That's the last thing you want to have happen. I think the data support the fact that the likelihood is super, super low, but it only takes one of those to be the face of the organization.
That's the truth.
That is exactly it. Yep, you're right about that. Hey, it's Jason Falvey. Thank you for spending part of your day with me here on In Service. If something from this episode hit home, maybe it reminded you of a call, a shift, or a hard lesson learned, follow the show and please send it to just one person and ask them to follow. Now let's get in service. So beyond C-spine clearance, what other scope of practice changes should Georgia be evaluating?
I think the big thing that we've done recently is adding the critical care paramedic endorsement. I think that's going to be a huge boon for the state, adding those additional skills. The Medical Directors Advisory Council, I think, has been very pragmatic about adding things that make sense. Again, some of the things that I think we'll see going forward, and some of these are added to that endorsement, but POCUS is kind of the big next thing. We've done some pilots here in the state, And we're currently having some pilots ongoing about vascular access, I think, in POCUS, and then looking at cardiac arrest, those kinds of things.
What about treat and release?
Yeah, the treat and release refusals always give me a lot of pause, right?
It's the highest risk.
It really is. It really is. We're fortunate here in this agency to have a partner that helps mitigate some of those lower acuity calls that we can hand off to another licensed provider. So that to me gives me a little bit more reassurance that we're not inappropriately not transporting people. I don't know, Chad.
The telemed aspect has changed the game, and the ability to put it off onto a licensed ER physician helps with that. I'm going to go back to the assessment part of it. Making sure that we do a good, thorough assessment is always going to be the biggest part of that for me. Is not just walking in there listening to somebody. For instance, we had one the other day. It came out as what they'd say is a lift assist. I am so proud of our paramedics for putting on a cardiac monitor, checking this lady. The outcome wasn't what I wanted. But whenever they found a STEMI after this person fell and do everything they can, I'm glad that they did that thorough assessment. Again, they say lift assist. It's not a lift assist. Gravity won. She fell. That's the real world parts of it. So they did a good thorough assessment based off of that fall and not what dispatch said as far as the lift assist goes.
But if it's a different crew that goes out there,
I can't promise the next
isn't
one
as proactive.
I can't promise that. I can't promise that you're going to get the same assessment right then. And I wish that I could, but I'm a very realistic person in knowing that that individual right there went above and beyond and put a cardiac monitor on, did a full assessment of somebody and found something. I don't know what would have happened if it was somebody else. I'd be honest.
Yeah, I had mentioned to you that I saw one of your medics in action last year, and he was pretty phenomenal. His assessment was right on, and he had no idea who I was and what my background was standing there, but he was really good. I thought he was very thorough.
Well, I think being a fire-based service that we are, they get to ride different apparatus all the time. So it doesn't get that true burnout type feeling on the same apparatus, but not just that. They get to ride with different people every time. So whenever they're rotating, they're not riding with the same individuals. So it keeps everything moving forward, and they're all doing something different. They learn each other based off of the day and who they're with and how they're with them. And they have ideas about how one person works and the other person works.
Right.
So if they're on the engine together one day and they're not on the ambulance the next day, then, they know how each other works. And that's the good thing about it. There's no real stagnation there. And what I find in a lot of places that I've worked that is just strictly ambulance based is that it's you and your partner versus the world and the negativity and all that stuff, because it's just you and them. And that's the reason I like the fire-based service. And I think that guys and girls do a good job of making sure that they take care of each other. They assess their patients. Is there going to be an anomaly? Sure.
Yeah. If you get the right partnership combination, they really are outstanding crews out
Absolutely.
there. But if it's the wrong combination, yeah.
Yeah, refusals still just give me a lot of heartburn. I mean, kind of going back to that point, you have to go into every patient encounter with the expectation that I'm taking this person to the hospital, and I really have to be convinced that the patient doesn't want to go. They have the right social setup. You give them an alternate treatment plan. They have some alternate destination in mind, like the family is going to take them to the ER or to the urgent care, or leaving somebody in their living room because they sign a piece of paper, to me, is not the right attitude to have. It goes back to the drop-down lists in the PCR, right? If I click weakness instead of stroke, it's 7 fewer fields that I have to complete. If it's a lift assist, the PCR becomes much easier, and I can get the refusal signed and go back and watch Netflix at the station. So I think having the mindset that I'm here to transport this patient and I have to be convinced otherwise is the mindset you have to have before you get a refusal signed.
And it's funny because we put telemedicine out there, and what I've noticed since we put it out there is the number of transports have actually gone up, and the telemedicine hasn't been utilized very often at all. So they're not even trying to utilize it as much as they are just putting the patients in in the
In the truck and going.
taking them to the hospital. It's kind of funny how it worked out, because I said that as soon as we started this. I said, what's going to end up happening is we're going to give them this tool that they wanted, and as soon as we get it to them, they're all just going to put them on the stretcher and take them to the hospital. And that's exactly how it's gone down. I think in the period of time, we've only had maybe 20 totals that have been utilized. And I'm sitting here going, all of y'all complained about wanting an alternative method, and then you don't even utilize that alternative method. So it's
At least you're giving them another tool that they can use if they need it.
absolutely.
Let's talk about your perspective, Dr. Allen, as a medical director. What do you think EMS providers underestimate about your role? Because you don't get to see them all, do you?
I try to see as many of them as I can.
Yeah.
Certainly with an agency this size, there are people that I haven't met. I try to be the guy that if I see them, if I see an apparatus at Kroger, I'll stop and try to go in and say hi. I don't want to be the medical director that if I came up and kicked somebody in the shin on the side of the road, they wouldn't know who I am. Which I think, unfortunately, there are a lot of services that have less engagement from their medical director than is optimal. There are some services that have the guy that shows up once a year to sign the license renewal, and then he crawls underneath a rock for the remainder of the year. Those services have paramedics that either feel overconfident because they don't feel like they have anybody looking at their PCRs after the fact, or you have people that are not confident enough to be able to do some of the more advanced skills because they don't feel like they're getting the engagement from the training and professional development side. I think it's important, if this is a role that you're going to take on as a medical director, to gauge the interest from the agency, but to be as engaged and involved in the process as you possibly can. Unfortunately, only a handful of states require emergency medicine training to be an EMS medical director. Now there's an EMS subspecialty. You can take a fellowship in EMS and get some specialized training and involvement. There's nowhere in the country that requires that to be an EMS medical director, at least on a regulatory level. Some agencies will require that. But
when we talk about protocol development or quality assurance, how much of it is developing a culture, a clinical culture that is moving towards excellence?
I think that's largely what you're trying to get at. Protocols are really just guidelines. The protocols are there to give the paramedic some guidance on what direction they should go with a particular patient. Nobody's going to fit into one neatly color-coded box. Like, it's not just an allergic reaction.
Yeah, you're going to have guardrails.
Yeah,
right?
I try to instill this in all the paramedics that I work with. If you can justify in the PCR, you have a good rationale for why you maybe strayed outside the guidelines a little bit, that's a conversation that I'm certainly willing to have. And it's not going to be punitive. There's not going to be any retribution, as long as you can defend the position that you're taking and why you did what you did.
A big part of that's not just calling out the bad, but looking at the good that they do as well. And that's where we've tried to focus on. We're going to hit them for protocol deviations here and there. They're going to have errors. We've tried to take most of the error capabilities out by utilizing medications and things like that that meet exactly the standards that we need, so they can't over-medicate or anything of that nature. What we've also found is making sure that they see the good parts that they've done, and we recognize those good parts, because if they only see us whenever it's bad, whenever they've made protocol deviations or anything like that, then we're not doing anything good for these people. That's where we've found the most success. We implemented heparin about a year ago, and now we're re-educating and making sure that we instill it back into their minds that it is there. A lot of the people that we work with aren't used to the critical care transport out of the hospital medication, so heparin is a new thing to them. Heparin is one of those medications that is usually been hospital held, and they've maybe transferred somebody out. So for us to push it out in the pre-hospital setting and utilize it for STEMIs, it's not something that they're accustomed to. We don't have but a handful of people that have ever worked at a private service that work for our organization, which is strange because most of your fire-based personnel go work at a private service on their day off. If they have worked at a private service, they haven't done the transfer stuff, and they don't understand what it was. So those things like that are the biggest parts of the protocols that we have to look at. And how do we get these people to follow these protocols or these guidelines that are set forth by him? And if it's not working, If what we already rolled out isn't working, how do we adjust this protocol? How do we adjust our training to meet this protocol's needs? The biggest part is not just setting something out there and never paying attention to it, setting something out there, watching it, see how it's going in the field. We've realized we needed to make adjustments as well. It falls back on me on the educational side. Me and him have worked on how do we adjust that specific protocol? How do we change it to make it not seem so constricted so that people are questioning themselves, and by the time they've figured out whether or not they can give it or not, they're already at the hospital.
And if you look at heparin, it's lower frequency. It's further down in the protocol. So you might not get to that point. And you're adding something in new. Yeah.
But I think going back to the education piece, you can't just throw a protocol out to the agency without the underlying why. It's like we talked about. And especially with heparin, the number of patients that you hear from a cardiologist that by the time they get to the cath lab, the vessel has got a little bit of flow through it. And maybe that's because we gave them 5,000 units of heparin in the back of the ambulance. So just giving the crew members the rationale behind why we do something. I think about when we adjusted the dose of ketamine after all of the goings on out west, just giving them the rationale behind why we make some of the decisions that we make, I think goes a long way.
Because they're not necessarily going to see the benefits of that medication during the course of that transport.
For them, it's a one-off thing that happens maybe once a month, once a quarter. Mm-hmm. So when we get the benefit of looking at the bigger picture, looking at the number of PCRs that we see, we look at all the STEMI patients, we look at all the intubations, we look at all of the extreme agitation that gets ketamine. We see all of the data, and they see just the one isolated patient. And it's harder to pick up the signal from the noise there.
Yeah.
The way things flow, it's like you have a group of people, and it's like a roller coaster. They'll get 10 STEMIs in 6 months, and it'll all be specific to one station, one shift, or one shift total. So this other shift may not see one for a year.
Yeah.
If we don't educate or continue to refresh their minds, that's not going to come up in that system.
If you're in one of the rural stations, you may not run a call for a couple of shifts, let alone see a STEMI in a calendar year. But when you do get that one, it's important for them to have that institutional knowledge of all of the other data that we see to understand why it's important to give the heparin or, do whatever it is in the protocol.
Should paramedics have greater authority in rural areas?
I think the rural dilemma is there are often services that are under-resourced. They have smaller budgets, smaller staff, fewer trucks, longer transport times, things that are working against the delivery of optimum care. I think there's a lot of benefit for having additional, maybe not additional certification levels, but I think you have to have engagement from a medical director and an agency in those environments that allow people to operate at the top of their license. Unfortunately, those are the ones that often you don't see that because they don't have the resources to be able to bring all of that to bear.
And you're also looking at a lower call volume, so lower exposure to patients.
Yep.
And then you increase that.
Yeah, but I think at the same time, though, the patients that they're often exposed to are the ones that need the highest level of care. So you get a trauma that happens in the middle of the healthcare desert that we have in Southwest Georgia can be a 2-hour transport. It can be an hour to get a helicopter to them to be able to transport them to where they need to go. I think those are the paramedics that need to have the most capabilities, the most professional development, the most skill development, but it's also the hardest place to get somebody to want to work in because the pay is often lower, the resources are often less, the schedules are not as optimized. So there's a lot of things kind of working against those agencies, but they're the ones that really need to be able to deliver the maximum level of care.
I think he's exactly right. And so every second job that I ever had in my career, I always went to a rural area. And the reason being is because in my primary job, I was always in a place that I could be at a level 1 trauma center within a short period of time. It taught me one side of the paramedicine part of it, but it didn't teach me the other side of it, how to maintain somebody for 45 minutes, an hour and a half. And it's a different world. I think he's exactly right. I think there is a need for that in that rural area, but the resources just aren't there to provide that all the time. I think as in the state of Georgia, as we see these hospital-based services take over, the ability to do that is going to be greater. The biggest part of it's going to be on the leadership side of it, on that service to maintain that educational piece that's going to be so crucial, because they're all going to be low frequency. They're all going to be high risk, low frequency events that these people are utilizing, these critical care tools. I think that these people do need to be the highest level trained in the rural areas because of the fact that there is that potential to keep somebody. Helicopters don't fly in the rain whenever it's really, really cloudy. They don't fly whenever there's a lot of different things that come into play right there. So,
and you might not be able to get a helicopter down depending on the area.
No, I never played that game. I always played the what if I have to drive this person an hour away? What if? And I want to be able to maintain that individual. So the need is there for more treatment options. But again, you have to do it the right way. And
I think it's more important for them to do a more thorough and appropriate assessment for those patients. When you're coming from that far away, you have one hospital you're going to take everybody to. In some places, it can make a difference if you are driving a little bit farther to go to a specialty PCI center or a comprehensive stroke center. Being able to make those destination decisions that are in the best interest of the patient, you have to be a master of your skill level. You have to master the assessment of the patient to know exactly what's going on, because you're the only provider that's going to take care of that patient for however long it takes you to get them to definitive care. Unfortunately, they're the most under-resourced, but the service that can make the biggest impact in terms of delivering that patient care when it needs to be delivered.
I think the transition, like I said, in the state of Georgia, you're seeing a lot of the hospital-based services come up throughout the state. And the resources that they have at those hospitals is what these services need. They've just got to figure out how to intertwine the two together, because they do have the ability to be proficient at RSI. They have the ability to do the ultrasounds, the stuff that they do inside of these facilities, and they have the ability to do it. They've got to let the EMS providers get engaged in the same thing that the nurses and the nurse practitioners and the PAs get engaged with. So that's going to be the most beneficial piece of the whole puzzle, making sure they have it. In the rural areas I was in, those calls were very low frequency. So making sure you're prepared for that event when it does arise. You have the tools now. Now I need to know how to utilize them.
Should critical care paramedicine really be considered a specialty track similar to nursing specialties?
When you look at the national scope of practice model, they only have 4 licensure levels. So similar to nursing, the critical care paramedic is just an endorsement on top of their licensure. Right. In Georgia, when we look at how that is delivered, it's not just an endorsement on the paramedics level, but the agency that they work with also has to have the critical care endorsement. So the situation that I see arising is you have a helicopter paramedic that works for a flight service. He has the critical care paramedic endorsement. But if he's working a shift with a ground agency that's not critical care endorsed, he can't utilize those same skill sets. So I think if you make it a separate licensure level, you can end up getting some confusion on what scope of practice activities that paramedic can perform based on where they're working. So I think when it's an endorsement, it makes it a bright line that if I'm working for the helicopter service or I'm working for this IFT agency, then I can use my critical care skills. But if I'm working for this ground agency, I can't, because the agency doesn't have that endorsement.
I'm glad the state of Georgia did what they did, and the educational requirements now being a whole lot higher than they were before, and the practical hands-on part of it's one of those things that I was looking towards. Here's what I saw before all that is that you had a bunch of people that would get their paramedic one year, the next 6 months they'd have their FPC or their critical care because they went through a fly-by-night critical care course. They tested and ended up passing. They have no knowledge of the job still yet. They've got the 6 months of experience. They haven't seen the things, but now we're putting them on a helicopter in the back of a truck with somebody just
And
strictly.
their only patient encounters are the ones that they got in clinicals during all of their education.
And we're putting them in the back of the truck in these critical care environments that they haven't ever dealt with ventilators. They haven't ever dealt with balloon pumps, these things that they're having to deal with in order to get that certification. And that's what scared me the most. I'm glad you got your certification. I'm glad you passed the test. Congratulations. A 48-hour class isn't enough to be managing somebody at the level they're managing them at.
Yeah, and probably alone.
Yes.
Yeah.
Absolutely.
Yeah. I could teach anybody with enough time and a big enough budget how to do any procedural skill, but I can't download experience into your brain so that you know when to do or when not to do it. And I think that's where, especially for these critical care patients, the experience is so much more important than the actual technical procedure skill ability. It's more about knowing what to expect and how to manage a patient that's critically ill because you've done it 100 times and you just don't get that from taking a test.
Right. I agree with that. Let's talk about leading through growth and change, because the county you're in has grown tremendously. It's still continuing to grow. Has that changed the way you think, Chad, about EMS operations and leadership? Your department's expanded quite a bit.
Yeah, I'm a huge advocate for the leader. Every time we do a meeting, I talk about leadership in some way, shape, or form, growth. In our organization, everybody being dual certified, except for a few, it's hard for me because I don't want them to be confined to a specific role in our organization. Our medical command staff is fire trained. They're fire suppression. They're everything. So I only have a group of 6 of them plus some backups. So we have a total of 16. It makes it easy for me to promote growth in them in every aspect. As we grow, we're going to need more of that youth to step up into the EMS role. EMS gets frowned upon because that's what we're doing 90% of the time, and people don't want to work all the time. So it's hard to get people engaged in that. It's going to take good people underneath me to promote growth in the youth underneath them.
Right.
That's why I said before, it's all about finding the right people for those positions, because if you get the wrong person, it's going to discourage them even more from EMS. We learned that the hard way. And now, looking back at it, I'm fortunate with the group that I have underneath me because they promote growth in everybody that they oversee. That drives them. They're out there working with them. They're out there engaged with them. They're not just running EMS calls. They're running every other call with them as well. And what shows these youth is this position's pretty neat. I get to go run all the good stuff in the whole county. I get to kind of be engaged with everything. And it's promoted a lot to where we have, before we couldn't find people to fill those positions. Now I've got people coming to me that want to get into those roles, the leadership roles and the EMS side of it as well. And it's fun to see the growth. It also concerns me about where we go with EMS in the future. I see both sides of it, and I think we've done a great job of promoting the growth. I've got people that I never thought would step into these medical command positions strictly because they were straight firemen. Mm-hmm. That's all I'm ever doing is I'm going to fight fire, I'm going to do this, I'm going to do that. One in particular, I love him to death. He told me point blank whenever he came into the backup role, he said, I'll never do a full-time role. Now he's sitting in a full-time role, and it's pretty neat to see, but it also gives them experience if they want to go back into a field operations or fire suppression as a battalion chief. They've had the ability to manage a whole south side of the county. So they're getting one up on everybody else that they're going to be testing with for those leadership roles in the fire suppression side of it, because nobody else has had that ability to manage 16 or 17 units a day, manage 30 to 40 people a day. That's the advantage of it. Marketability for those individuals going into that testing process is, I've had the ability to be on a car by myself. I've had the ability to manage this, and this. You can only get those by doing these jobs. We're getting a lot of officers that now want to step into those roles because they're seeing the ability to do the same exact job, but you're riding by yourself and you're having the ability to lead a whole lot of people. That's good.
Yeah.
Yeah, it's a culture shift, right? It's really an EMS agency that happens to suppress fire on occasion, which is not really what everybody wants to, not what they want to do. But the reality is, if you take away the non-fire calls, like the false alarms, probably 90% of our call volume is EMS or EMS adjacent.
I would say that about most places now. The fire marshal's office, the fire outreach, the educational pieces of the fire side, and then building, coding, everything like that has changed the game as far as the fight and fire part of it. There's still fire, and we're still going to always have that no matter what we do. And there's always going to be those gas leaks and fire alarms and everything that comes along with the fire side of it.
Yeah, and structural collapses and extrications.
It's funny because now those become low-frequency, high-risk calls a whole lot more than they used to be in the past because things have changed. Coding has changed. Structures have changed. Everything's changed on that side of it. But we are running a lot more of the EMS stuff, and people are seeing – it's been fun to see the outcomes that they truly make in somebody and how it drives them back to the EMS side a little bit. And it's like I tell all of them, I want you to be great at both if you can. I want you to be great at both of them. It's your job. EMS isn't your job. Fire's not your job. They're both your job, and I want you to be great at both of them. So whatever tools we can give them to make them grow, that's what we're going to do.
What operational challenges do you think doesn't get enough attention? Because there's only so much you can do.
I think this is probably a big thing across the board with EMS is they don't understand the financial obligation, the reimbursement parts of it, how we're not the same. We're not looked at the same as a medical facility whenever it comes to reimbursements. We're not always getting reimbursed. We're transporting a lot of people that don't necessarily have the ability to pay, but we don't have the ability to say no. We get them to the hospital. We take care of them. So they don't understand that. Everybody wants something, but they don't want to understand how we get that something.
Yeah.
Those are things that I think is across the board. The leadership aspects need to be open and honest about why we do the things we do. They'll understand it more. They'll understand the benefits behind it. They'll understand, yes, it's maybe just a little bit more work to get this information, but if we understand it, at least we're more willing to do it. Ultimately, that's the biggest challenge that I face is the financial sides of it, the cost of trucks, the cost of cardiac monitors, the cost of everything is not going down, it's going up. So we have to maintain that part of it too.
Yeah, and the reimbursement model is a transport model. You put them in the truck and drive them to a destination requirement.
You don't get paid if you don't take them to the hospital.
That's what it boils down to at the end.
Even when you do get paid, it's not the same pay structure that you would expect for a transport to the hospital. Private services versus a county, city-based service are completely different about what they're willing to charge people, how they're willing to go about stuff like that. It's just a different ballgame for us.
I think blood product administration has been demonstrated to have one of the biggest mortality benefits in acute blood loss.
Yeah.
But you don't get reimbursed for that specifically. So, I mean, that's cost that you just end up eating as an EMS provider that, the government just hasn't caught up with the research yet. So, is it something that we feel as a service that we should be providing? Absolutely. Are we going to get paid for it? Absolutely not.
Yeah.
And we're fortunate in our county to where we have good commissioners, good county managers, the backing to be able to provide these things. And we're truly lucky to be in a county that we're in with the backing that we have from the political level. And our chief level. They're all about it as well. No, do everything.
Yeah, when we ask a question, it's always a matter of trying to figure out how to make it work. If it's a no, then there's a good reason that the answer is no, but it's not the fact that it's not well researched. There's a good reason behind it.
We don't go ask to things before we've done our due diligence to provide them with everything we can provide to show them how beneficial it is to the citizens of our community and or the organization as a whole.
Right. What metrics do you think? Obviously, you guys track a tremendous amount of metrics. Which matters the most from an operational standpoint and from a clinical standpoint?
Gosh, that's a tough one.
That's a tough one. I mean, there are so many data points that are out there. There are a lot that don't matter. The big ones, I think the one that you'll find that matters the least really is overall response time. I mean, I think you have to look at the type of call that you're responding to, right? There's a big push to reduce red light and siren use. And when you're held to the standard of getting to every call within 7 minutes, irrespective of the type of call, then I think you're doing nothing but putting your crews and the public in danger. So I think it's important to start looking at those in terms of response times for the calls that are the higher level responses. I think when we start looking at metrics specific to particular call types, looking at cardiac arrest, which is a big area of focus for us recently, looking at time to CPR initiation, time to first defibrillation, all of the metrics that really have been shown to increase patient survivability.
I would think a number like first pass success ratio.
Yeah, I think
way
that's
better, way more important than
Yeah, 100%. I think there are millions of data points that you can collect. 99% of those probably don't make any operational or clinical benefit. But I think from an agency level, that's something you have to sit down with your QA and QI people and figure out what makes most sense for your agency, because those data are really going to vary from one place to another.
I think you're 100% right. It's going to be based off the type of calls that you're running in your communities. Community-based evidence is going to be the biggest part whenever you're looking at clinical, what we run versus what other counties may run. They may look at the data completely differently than what we are.
Looking at trends too, particular call types that you've seen lately that you're trying to make a difference in a particular call type. You may want to adjust the metrics that you look at based on that recency of call type.
And the operational side of it, I'm looking at total call volume versus staying in the county with transports versus going outside the county with transports. Anytime we go outside the county or we go to a facility that's a little bit further away, how long is it taking for us to get back in service? How long is it taking for us to get back into the county? And those are things, so you're looking at a 30 to 45 minute extra window for going to certain facilities versus other facilities. So how do I provide, it doesn't have anything to do with the facility. I want my people to do the best assessment and take them to the right place where they need to be. But I also want them to do the good assessment, find out where these patients need to be, and get our resources back to our community the quickest as possible. Because ultimately, that's what's going to reduce our response times. That's what's going to reduce the mortality rates. Everything that we look at as a metric is going to be based off of how quick can I get these trucks back into the county, back in service. And this goes back to the community-based hospital, trying to give them the data that they need. Because if they want to go after certificate of needs, where's the biggest part of it going outside the county? Where's the areas that we need to work on? And if you don't want to work with your local community hospital, you're doing yourself a disservice on a 911 side, because the more they can handle, the more I get to keep my trucks in the county. It's a whole lot easier for me to get them to respond from that area than it is to respond from outside of a county.
Yeah.
I think the state office in Georgia has done a really good job in the last several years looking at offload times. Certainly during COVID, there was a lot of hanging out on the wall for hours waiting on a bed. So
it could be 6 hours.
Oh yeah,
or more.
Yeah. So they have an ambulance offload time task force that they put together. Those data are presented on the state office website, so you can see what wall times look like. I think that's another metric that's important, is the turnaround time, getting your crews back in service. We've had a lot of support from the state office to try to minimize those times.
Talking about offload times, what do you think is the driving factor behind that? Is it ER beds, available beds?
I think a lot of times you'll see a lot of holds. You'll see nursing staffing shortages, for whatever reason. Sometimes there's a mindset that it's not our patient until you put them on our stretcher, which is not really the case. I think it's a multitude of factors, but a lot of times it's a capacity problem in the emergency department. Locally, we've had really good experiences with the hospital systems here. They have EMS offload areas where they'll have dedicated staff that we can put our patients into and get back in service really quickly. I think it's important to build those relationships with the hospital leaders where you deliver patients more frequently. And Chad has been really good about that here locally, developing those relationships, being able to escalate things when we have a unit that's sitting on a wall. We have benchmarks to where at 30 minutes we call this person, at 45 minutes we call the next person, at an hour we're waking up one of the senior administrators at the hospital.
And I even go as far as trying to help them out with the trends, as well as areas that offload times are greater than the others. They can look at staff, just like if they see areas where we're not doing great, they can let us know. The ability to work together and not take it personally, because we're all in this together. Right. And I've realized is that I can pick up the phone and make a phone call and we can have it worked out in no time. If they need data, I have no problem giving them the data to show our offload times are bad between 7 and 9 on this day. I don't have their schedule. I don't want their schedule, but they have the ability to look at their schedule and find out if it's a pattern based off of staff, if it's an educational thing that they need to look at, if it's a bed, all hospitals shut down certain areas at nighttime. Is it something that there's a time frame that we need to look at trying to keep beds open a little bit longer? Right. But they need us to have that data. They can have it on their side, but they also don't have all of it. So it makes it easy for me just to give it to them and show them, hey, here's your patterns. I don't know anything about what it is, but here's your patterns of times, days, and they can narrow it down from there. And our local hospitals have been absolutely phenomenal with that kind of stuff.
I think the biggest thing is just developing those relationships with the people that make the decisions, so that every time you call them, there's not a problem. You show up with coffee, or you shake hands, or you have a conversation about something not work related, so that you don't get that mindset that, oh, geez, it's Chad calling me again. What,
I don't want Chad showing up.
Yeah.
Exactly. But having those relationships with people forged ahead of time, I think streamlines that whole process of working out problems in real time.
I can remember during COVID, we had a crew come in service. They ran a trauma call. They sat on the wall for 8 hours, basically.
Yeah.
Yeah.
They had about an hour and a half of downtime that entire shift, 12-hour shift. Time on task, 10 hours.
Yep.
Absolutely.
Yeah.
That was just a crazy time.
Being able to call the people that are in the department, or if they have a problem on the EMS side, being able to call Chad or myself and say, hey, this is the situation. What can we do to try to fix it? Those things are so much more easily sorted out with a quick phone call than a 42 email thread that goes back and forth between administration and a bunch of people that don't need to be involved.
Escalated for no reason.
Yeah.
I'm going to pull out one more question here, and then we'll move towards wrapping it up. Looking back over your careers, what leadership lesson had you learned the hard way?
Man, there's a lot of them. Do I start? I think the biggest thing for me is going into every patient encounter and trying to treat that person like their family. It's easy in the course of a busy shift to get beat down and burn out. And, oh man, it's this guy we've run him 8 times this week, and all he does is call 911 for no good reason.
Man, that is a challenge.
It
You've
is.
seen that guy 6 times.
We all
this
know
week.
we all know that person, or we have 10 people in our agency that could describe. But
There are some people, we could run them 3 times in a day.
100%.
Yeah.
But eventually that person's going to have an emergency, and you never when it's going to be.
And as a physician, right? Gosh, that's going to be it's frustrating for us, but I can only imagine when you open the curtain and you see that guy again.
That's the refusal that scares me.
Yeah. We've had those, we've had those refusals that have turned out not so great. But, I think the most important piece is going into each encounter with that open mind and not allowing your interaction or somebody else's interaction with that patient skew your perception. Because it's easy, like the nurse comes out and says, oh, Johnny's here again, or, the paramedics start out that way. And then you go into that encounter with a completely skewed perception. You don't do a thorough assessment. You don't talk to the patient enough. You don't get a good idea of exactly what's going on that day, even if it's the same thing that's been going on the last 8 times you've run the patient.
Even the boy who cried wolf is going to have a medical problem one day.
100%. And the last thing I want to do is to have my name last on a chart when there's a bad outcome, so.
Yeah.
I don't think anything in particular has shaped me. I have a saying that has shaped me. They always said adversity builds character. I said adversity exposes character. And it's our job to fix and make ourselves whole. I've faced a lot of adversity in my career, and I could have stopped at any point and said, this isn't for me anymore. One of the things that I try to push people to understand, that you're going to face adversity, and you're going to be uncomfortable, and you're going to have challenges, and you're going to fail, and you're going to mess up, and to keep pushing forward. That was one of the biggest things for me. It took a long time for me to understand that these adversities that I was facing, that I was holding on to, weren't building my character. They were exposing parts of my character that I wasn't fond of. And it was time for me to change those parts of it. Whenever I look at leadership, how do I push people behind me to be way better than I ever could be? And that's one of the biggest things that has put me where I am today. I don't want to be the best. I want everybody around me to be better than me. By the time I leave here, I want them to be way past me. And a lot of people try to hold people back so they never catch up to them, and I'm the complete opposite, is that I'm always taking classes, making them catch me, and I want them to catch me, and I want them to pass me, and that's
That's leadership right there.
We talk about leadership, but you got to get the people to follow you. That's what real leadership is. And you got to get them to come with you. And that's the big parts of it that you can talk about teaching it all day long, but it becomes difficult whenever it comes down to actually teaching those leadership styles.
Dr. Allen, Chief Huff, thank you so much for doing this. You guys are fantastic. You have a great relationship, and you're doing some wonderful things in the county. And I appreciate you coming in. I'd really like to have you back to do another episode.
Absolutely.
Yeah,
Right.
fun.
Thank you.
Thank you for listening to In Service, the EMS podcast, where frontline experience meets leadership insight. If you have found value in this conversation, please like, subscribe, share, and leave a comment. You will find links in the episode notes.